Succes i veterinærpraksis, podcast nummer 93. Dyrlæge Søren Pejstrup her. Jeg vil gerne starte i dag med at sige mange tak til alle jer, der bruger tid på at svare, når jeg spørger, og på e-mail og andre steder online, og når vi mødes ansigt til ansigt. Det er rigtig dejligt, at I har lyst til at bruge tid på at svare på, hvad det er, I bøvler med, og hvilke emner, der er værd at tage op her i podcasten. Og det er dagens podcast nemlig et resultat af. Fordi flere af jer har nævnt, at det er svært for jer, eller I synes, det er frustrerende at have patienter liggende i narkosen, som ikke ligger rigtig godt, og det er svært at få det her TIVA-narkose til at fungere, uden at de ligger og spræller, og man hele tiden skal skrue op og ned, og det er svært at holde dem ordentligt smertedækket. Så derfor har jeg prøvet at tage det her emne op. Vi kommer også til at snakke mere om narkose senere hen. I podcast nummer 29 snakkede jeg med Helle Harding om smertestillende stoffer generelt, og den episode kan du gå tilbage og finde enten i din telefon eller på hjemmesiden. Det var altså podcast nummer 29. Og i dag der skal vi så snakke om smertebehandling i forhold til narkosen, og primært i det postoperative forløb. Men sjovt nok, så involverer det også en del af præanæstesien, og det involverer også lokal analgesi. Og det bevæger vi os ud i dag, fordi de er alle sammen en del af det at få patienten til at ligge ordentligt, så at sige, i narkosen. Og så snakker vi også om sådan det helt lavpraktiske i, hvordan får vi overhovedet det her til at fungere i en travl hverdag, og hvem skal betale for det. Men det kaster vi os ud i dagens episode. Kig over på hjemmesiden på SIVP.dk/93. Der finder du links og noter til dagens emne, og så over til interviewet. Hi Tasha, and welcome to the podcast.
Hello, thank you for having me.
So we chatted just for a short while over email and in your Facebook group, but can you please give the listeners a short introduction to who you are and what it is that you do?
Sure. So my name is Tasha McNerney, and I am a specialty technician in the United States. I work just outside of Philadelphia, and I am a specialist in anesthesia and pain management. So my focus every day is making sure patients get the best anesthesia experience they can, and making sure their pain is well controlled preemptively and postoperatively. And then, for our older patients, I do some work with chronic pain management as well.
So you have a pretty wide range of patients then?
Yes.
Yeah.
Yes.
In talking to some of the listeners, one of the pain points, no pun intended, that comes up is the pain management around surgery. And sometimes the patient is difficult for us to control during anesthesia, and it's difficult to manage the pain afterwards. Sometimes it's because we are in a busy clinic and we don't always have the time, and sometimes because maybe we don't listen to the nurses or to the technicians to be honest. So my hope was that you can help us in let's say elevate the level the level of knowledge just a little bit, so we can maybe do better pain management for our patients.
Of course. I would say that probably the most important things to consider when you're really trying to provide the most pain control for a surgical patient is to give them some good analgesic drugs preemptively or as part of the pre-med. So for us, that means opioids, and opioids like hydromorphone or fentanyl or methadone. The opioids, I know they're opioids, but drugs like butorphanol, because they are not full mu opioids, they don't tend to have as good a pain management qualities. So if you're talking about orthopedic procedures or an abdomen being opened surgically, or something painful like a dentistry. 'Cause now our patients are having a lot of dental procedures done, and we're doing a lot of dental extractions, and those can be painful. So we want to make sure that we're providing the strongest opioid that we can in their pre-medication. And then we want to make sure that during the procedure, so if you're using opioids, that's one thing. And then the second most important thing me personally, and I like to talk about is the use of local blocks. So local blocks are the only thing that are really going to completely stop transmission of those painful nerve impulses. So we utilize everything from epidurals to incisional local blocks to all of the different dentistry local blocks. Pretty much any surgical patient or dentistry patient gets some type of local block during surgery.
So I think some vets tend not to use the local blocks. I don't know why. Maybe because we are not quite sure how to use them, or maybe just because they take up time that we think we don't have. But what for in general practice, what is good for a local block? What is easy to use?
So are you asking which procedure is the easiest, or what drug would we use?
Kind of both, actually.
Okay. So for us, we tend to use a local block for everything. But if you're in a general practice and you don't think you're going to be doing epidurals, or you don't think you're going to be doing a thoracotomy, so maybe you're not going to be doing, regional site-specific blocks like that, or more extensive blocks, you don't have a nerve stimulator. If you just want to do a basic block, you can do a basic incisional block where you just do bupivacaine along the incision line, and that'll help provide some pain control in the postoperative period and lessen the amount of overall opioids you're going to need in the postoperative period. If you do something like an intratesticular block for your dog neuters, that can help significantly, because a lot of times what can happen is that the animal seems like they're at a stable plane of anesthesia, but your doctor goes, they pop out the testicle, they start pulling on that ligament. Now my animal's starting to wake up. Now the technician has to turn up the inhalant anesthetic. And we know when we turn up the inhalant anesthetic, that's going to vasodilate our patient and then maybe cause them to have lower blood pressure. So we really don't want that. So if you could do something as simple as a intratesticular block, it's super cost effective. It's very easy. Your technician can do this. It doesn't require a lot of extensive training or special equipment. And that will save you not only anesthetic time, but it also makes it a little safer for your patients because you don't have to then crank your isoflurane or sevoflurane up to a high percentage.
And you talk also about nerve stimulators, and for those who don't know, it's a small device that will help you find the right nerve where you can put your local block, right?
That's correct. So I work with an anesthesiologist, and I also work with a few surgeons. And at the one practice, we do quite a bit of knee surgery. And for a while, we were using epidurals. And epidurals are a great choice. Don't get me wrong. But if you can go specifically and only block the femoral and sciatic nerve of the one leg, then you avoid some of those complications of epidurals that you might get, like urine retention or, hind limb, both hind limbs being out, and then your nurses have to pick up this animal. Usually animals who just have a femoral and sciatic nerve block as opposed to an epidural are up and around faster and walking faster than the animals that had the epidural. So still, I don't want it to sound like I'm against epidurals because I'm not. They're great. But using a nerve stimulator to specifically find those nerves and put your local anesthetic near those nerves can help increase or enhance the effectiveness of your local block.
Yeah. So you can actually, I've seen this in practice, and I've tried it a couple of times myself, and it's pretty fun actually. To be honest, I think that kind of stuff is fun. But you can basically turn off the electricity in that leg, and you can keep your patient on a fairly low dose of anesthetics, even if your surgeon is making a pretty large hole in the leg.
That's correct. And then some of my lectures that I've done, I had an example video. I had a patient that was getting a TPLO surgery, and we had given nerve blocks, and you can hear the saw going in, and you know that it's pretty traumatic. And then I panned over to the inhalant, and I had my inhalant at sevoflurane at 1%. So be able to keep your inhalant very, as low as possible, but also keep your animal or your patient pain free. That's really anesthetically what we strive for.
Yeah. So going back to the drugs and maybe the post-op pain management, why are we talking about the pre-meds and the local blocks in post-op pain management?
Well, because what you use beforehand and during your surgery is going to greatly influence how that patient recovers from anesthesia and recovers from the surgery. And if they have a nicer, smoother preemptive pain control, and if they have a nicer, smoother anesthetic process, and then they have a nicer, smoother recovery, they're going to need overall less analgesic drugs to go home. And especially now that there are some more long-lasting drugs on the market, and I know it's not a problem, in the UK and in Europe, but for the United States, we've had a bunch of regulations now that we can't prescribe and we cannot get our hands on the same kind of opioids that we once could. So now we're being forced to think outside the box and, provide as good pain control we can in the before period. So that way, when they go home, we are kind of, we're ahead of the curve a little bit, so that we can then send them home with something like a non-steroidal anti-inflammatory.
Mm-hmm. So it actually also makes the surgeon looks nicer. It makes the work looks better, actually, for the client.
Certainly. And now I think that it's a little different now than it was 10 or 15 years ago. So many people, these animals are a part of their family, and they know that if they went in for surgery, that their surgeon would give them an opioid and they would be put on local blocks. If you went in for shoulder surgery, you would be given a regional local block and you'd be given systemic opioids. And so our patients are getting that same level of care. And I think the owners now want that same level of care for their patients, for their pets, their family members.
Of course. But I'm also asking because I'm looking for a way in with my colleagues, maybe, or a way to sell the idea of this. We need more than one bottle now. We need to have multiple medications at play here, and we need to know about acting times and onset time, and it makes from the outside it makes it a little more complicated. So I need some good arguments to make people or myself and my colleagues think more about this.
Right. Well, one of the biggest arguments, is it's just the best patient care to provide very, preemptive and postoperative pain control. The idea that an animal will be quiet after surgery if they're in a little bit of pain, we're getting away from that. Whereas we want them to be up and active. We want them to be up and eating so they can recover faster, because we know that good nutrition is key to recovery as well. So we want them to be up and part of the family and in eating again. But also what I found interesting really is it can be very good for your practice's economics. When you look at the cost of local anesthetics, simple local anesthetic injections, such as an intratesticular block or an incisional line block, the cost of that versus the cost of turning your patient up to 5% ISO with the increased oxygen costs, actually it's not that different. So you can charge the client for the added pain control. And that's what we've done at our practice. We just have a regional anesthesia. We have a regional, like a local block charge. It's not very much, but it is a little bit. So what we do is we tend to just have a conversation with the client that, if they went to the dentist and they were having teeth extracted, they would have a regional nerve block to block, that sensation. And we explained that that's the same thing that we're doing for their pet. And we do a small nominal charge. And we have not had any owners refuse that charge or not want that charge. And I think when you talk to the owner and explain to them that it's, the same that you would get if you were going to the hospital or you were having a surgery, and we haven't had any owners not want that for their pets. No. And again, I think that it takes skill, and it is taking some of your inventory. So you should charge a little bit for it. It doesn't have to be a huge charge like you would maybe an epidural catheter. That could be inexpensive for the owner, but a simple regional block, at our practice, we only charge about $12, $12 US. So it's not a ton, but if you were charging every single one of your surgery patients an additional $10 to $12, you will make back that money, no problem. Yeah. And it increases your nurses and your technicians. Now, in some countries, technicians are not allowed, or nurses are not allowed to perform epidurals. But if you're just talking these more simple regional blocks, it can save the doctor a lot of time. While the nurse is performing the block, they take 3 minutes. That's time that the doctor could be using to get ready. They could be making phone calls. They could be really connecting with the client or getting their work done. And then the technician can be getting things ready and prep for surgery with the local block. Mm-hmm. And also from the nurses that I've talked to, it really does increase their job satisfaction. Most technicians and nurses got into this because they want to help their patients feel better. And if they feel like they are providing the best pain control and they have some role in that, that increases their job satisfaction. And it also increases employee retention. So it can have, a big ripple effect within the practice.
And the last argument there is actually pretty important, I would say. Yes. I think as far as the, nurses and technicians overall, we want to be a part of the team to provide some really good care for our patients. And that's what we really enjoy doing. And if we are at a practice where we feel like valued and we feel that we are a part of that team, then we're going to stay at that practice longer and, invest more in the practice and be a greater part of the team, which is only going to be better for the patients overall. Of course. And I think I might have got us off on a tangent there, but to get back to the patient. So it's in the operating theater now. If we somehow forgot to do a nerve block, is there any point in putting it in after the surgery?
Yes, certainly. Anything that you can do is beneficial. There is some evidence, I believe, to show that if you put it in subcutaneously, if you put in some local anesthetic subcutaneously, that will last longer than if you just did what's called a splash block or splashing in, the local anesthetic in. The splash blocks don't tend to last very long. So if you are going to use local anesthetic in the postoperative period, or if we forgot to do it beforehand, what we'll do is I will just come in after everything's cleaned up, and before we move out of the operating theater, I will do a line block of local anesthetic along next to the incision. And that just helps keep the patient comfortable.
Oh, yeah, sorry, but just right next to the incision?
Correct.
Okay. And that will still give some relief for the patient, of course. Yeah.
Yeah, so, that area is going to be that area because where you cut, it's going to start having all those inflammatory mediators going, sending signals. So if you can cut those signals off for 6 to 8 hours, that's just going to make your patient more comfortable.
Yeah. I actually forgot to ask you, do you use non-steroidal drugs in the pre-meds?
So that's kind of not controversial, I guess I would say. It's just everybody's a little different. Mm-hmm. And if we have a young, healthy, hemodynamically stable patient, most of our doctors will give a nonsteroidal anti-inflammatory before surgery. Mm-hmm. And that's just going to help, again, in that preemptive pain control, because we know we're going to be inducing inflammation in these patients. So if we can get something into them before the inflammatory cascade starts, that's just going to be better for them. However, because nonsteroidal anti-inflammatory drugs are not completely benign, if you have a patient that is not hemodynamically stable, or if they have some kind of kidney or liver insufficiency, we will not give that drug until after the procedure, because we want to make sure that our blood pressure has been maintained during the procedure. Mm-hmm. So it really is you have to look at your patient and decide, can they handle this? If it's a young, healthy patient, they probably can. But anything older, any, chance of kidney disease, we would wait until afterwards. Yeah.
And in the optimal world, you would also have a blood sample before the surgery to show you.
Certainly.
Yeah. Well, you can't, of course, see all kidney problems on a regular sample, but it will maybe take some of the worst cases take the top of some of the worst cases.
Yes. Yeah. And here we tend to see a lot of older patients come in for dentistry. Mm-hmm. And so they almost always have concurrent kidney or liver issues. So for those ones, we want to check blood work before we put them under anesthesia, and then we wait to see how was their blood pressure during the anesthetic event before we give them nonsteroidal anti-inflammatory drugs.
Yeah. I was taught in uni a little over 10 years ago that it would also increase bleeding times. Do you see that at all?
We don't tend to see, I guess I can't say that I have appreciated it much clinically. Mm-hmm. I will say that there does tend to be more with certain types of nonsteroidal drugs, the COX-2 specific drugs versus drugs like Tylenol, which, COX-1 and some COX-2. So I think it depends on what, if you're using paracetamol or if you're using carprofen, which type of anti-inflammatory drug you'd be using. Mm-hmm. But for us, we are mainly using carprofen here. Yeah.
And you can give that IV as well, right?
You can, yes. Yeah. You can give it sub-Q or IV.
Yeah. And the reason why I remembered to ask you this now is because when the patient leaves the operating theater is usually when we will remember to give it some non-steroidals.
Yes, and I would say that probably 70% of the patients that I encounter are getting it at the end of surgery or when they're leaving the theater.
Yeah. And would you give it IV just to have it on board as quickly as possible, or doesn't it matter?
I would say that when we give it sub-Q, the thought is you have about 30 minutes. So we tend to give most of ours subcutaneously. But again, I think it's doctor preference. Mm-hmm. When you work with 12 different doctors, every doctor has their own, what they were taught in university and the way they like to do things. So,
of course. And it must be actually a challenging job to have. Juggling all that different.
It can, yes, it can be at times. But again, I think as long as we're all there for, the same goal to provide a good analgesic experience for our patients, then we usually can meet in the middle most of the time.
Okay. And this might be a little too general question, but you might tell me afterwards. But if the patient had gotten a good pre-medication and we did a fairly good local block and remember to give it non-steroidals, would you usually need anything else in the post-op period? Let's say for the older patient with dental work, or for the cat that got castrated or something similar?
Probably not. If you know your local block was effective, for instance, you were able to keep your inhalant very low, if you know you gave a good dose of nonsteroidal anti-inflammatory and you gave a dose of decent opioid in your pre-med that will last, up to 6 hours, then no, I don't think that you would need to give anything additional. unless your patient was having a very rough recovery. And every once in a while, we do have patients that really, they don't read the book and they will have a very rough recovery. And then that's when we might have to give them a little something additional. Usually at our practice, we're reaching for a drug like dexmedetomidine. And we do what's called microdosing of dexmedetomidine for our patients that are dysphoric from opioids or just generally having a very rough recovery. Because we don't want them thrashing around in their cage after surgery.
No, and they can also be, I want to be honest, they can be a bit noisy, and they can put a bit of pressure on the rest of the staff if my patient
yes. And around. Yes. And, the other animals that are in the treatment room can be affected by an animal having a really rough recovery. So.
And you say low dose. How low is that?
So for our animals that are having a rough recovery, we tend to use a dose of 1 microgram per kg IV of dexmedetomidine. And that just tends to settle them down a bit. Also, dexmedetomidine is really nice because it works together with opioids. So if you have opioids on board, the dexmedetomidine can work synergistically with the opioids to provide a little bit better pain control. Just because the way dexmedetomidine works in itself, it can provide some pain control too.
Good. So if let's say that we did something wrong, or maybe the patient didn't read the book, and it seems to be in quite a lot of pain, or we did something more violent to it, what else do you use?
Well, we start with dexmedetomidine, and if we feel like that's not enough, because again, dexmedetomidine works together with opioids, but dexmedetomidine in itself is not an excellent pain control. So sometimes we will have to start them on constant rate infusions of opioids, or even some of our patients will go on a constant rate infusion of a drug like ketamine. If we know that we have done something more invasive, or we are going to keep them in hospital for quite a long time, and we want them to be calm and settled and pain-free, that's when we have things like, we'll set up a syringe pump with maybe a low-dose dexmedetomidine CRI or a ketamine CRI, something along those lines.
Yeah. And if that actually is the last of the questions I have in my mind here, but I know from the Facebook group that a lot of different questions pop up from time to time. I haven't been too active there because maybe pain medicine isn't my strong point. I know it, and I learn a lot from the Facebook group, but I don't always feel I have something to share. But maybe we could talk about some of the common questions that you see in your Facebook group, or if you can remember some of them off the top of your head.
Yeah. So the Facebook group is Veterinary Anesthesia Nerds, and we have about 32,000 members around the world. And the nice thing is that we go through different cases, and if people have questions about drug protocols or pain management protocols, we just collectively, there's a bunch of doctors and nurses on there, and we all talk together about the best options. For instance, this morning, we had somebody post a picture of an ECG tracing that they were unsure of during anesthesia. And, it was a dachshund under anesthesia for dentistry, and she was just unsure this ECG tracing. Could it be a problem? Could it be interference? And it's nice to have that collective mind there if you're feeling unsure about something. And also what I really like about the Facebook group is that there's so many members. However, it's such a positive atmosphere. Everybody is there because we all just want to learn better, and we want to do better for our patients. And I think that that's been one of the greatest things to see for me, as the person who created it, when we started out with only 12 people talking about anesthesia and pain management, and now we have thousands and thousands. So to talk about different ways we can make things better is pretty amazing. We had a doctor, from Kenya, right in, and had very little supplies. So I think it also makes us, look at what we have in our clinic and realize how lucky we are to provide some of the high level care. And there are people around the globe, in Africa, in the jungles, trying to make things better for their patients as well. And they're trying to learn too.
Mm-hmm. And what amazes me with your community is that it's so positive, and the speed of which the answers come in is pretty impressive. I must say, I manage a couple of Facebook groups as well, and the tone has been different over time, and sometimes it gets not so kind. Just put it nicely. And
I agree.
I haven't seen any of that in your Facebook group, so that's pretty amazing, I would say.
Yeah, I work with the other administrators, Stephen and Darcy, who helped me greatly, and we all kind of police the comments, and we want to make sure that we keep it positive, because there are some people who are coming into this brand new and they don't know, and they're really just trying to do the best they can for their patients. And I think that we owe it to them to help them to answer their questions and to make it a positive experience so that they can learn what they need to learn and then go teach somebody else how to do better pain management and anesthesia. Mm-hmm. That's what it's about, creating this kind of global effort to elevate the standard of care when it comes to doing really good anesthesia and pain management.
Yeah. And I don't know if you want to talk about this as well, but then we will cut it out. But you put on conferences as well, don't you?
Yes. The Anesthesia Nerds has a symposium in Las Vegas. It happens in Las Vegas in October. This will be our third year doing it, and we get some world-class speakers. We have anesthesiologists who come and speak, and we're going to be talking about everything this year, from how the ins and outs of the actual anesthesia machine to things like how to interpret problem EKG patterns under anesthesia. We're going to be talking about local anesthetics and more advanced local block techniques for your patients. So we have it's a really fun time. It's kind of aimed for people who are really, really interested in anesthesia and pain management. Yeah.
And you're sold out this year as well. So when people are listening, it is actually already too late. But
we actually do have we have a few seats left. Okay. We are almost sold out, but if anybody wants to come to Las Vegas, if you want to come to Las Vegas in October and talk about anesthesia and pain management, we'd love to have you.
Okay, perfect. I actually can think of a couple of Danish vets that might be interested, so I might send them a word. Good, Tasha. It's been great talking to you. Just for the one last time, where is it that you work, and please the name of your Facebook again, please.
Sure. So my name's Tasha, and our Facebook group is Veterinary Anesthesia Nerds, and I work at a couple of different practices outside of Philadelphia, Pennsylvania, in the United States.
Good. Thank you very much, Tasha. It's been nice talking to you.
Yes, thank you so much for having me, and let me know if anybody has any questions.
Lige nu er jeg ved at arrangere et kursus, et gammeldags klassisk kursus i TIVA-anæstesi. Og tanken er selvfølgelig, at der skal komme en digital version af det senere hen, men i første omgang skal vi holde det fysiske kursus, og det holder vi i Odense her i slutningen af oktober i år. Hvis du vil vide mere om det, så kig over på hjemmesiden, eller skriv dig op på nyhedsbrevet, hvis du ikke allerede er der. Der sender jeg selvfølgelig information ud omkring det. Det er tanken, at vi skal lære lidt om, hvordan vi undgår at bruge gas, hvad vi skal holde øje med, når patienterne er i TIVA-narkose, hvordan vi får dem til at ligge stabilt, og så skal vi i øvrigt øve os på nogle helt rigtige dyr af den art og de arter, som vi arbejder med i klinikken til daglig, så vi får hunde og katte, vi skal arbejde med. Det kan du alle sammen læse og høre mere om over på hjemmesiden på SIVP.dk/TIVA. TIVA. SIVP.dk/TIVA. Links og noter til dagens afsnit finder du som altid under episodens nummer, og det er på SIVP.dk/93. Der er selvfølgelig også links til det her med TIVA-narkosen. Der kommer meget mere om det. Vi ses og skrives ved over på hjemmesiden.